So hello everyone, my name is Sarah Eisinga and I'm the Manager of Patient Programs, Research and Advocacy here at Lymphoma Canada. And I'm pleased to welcome all of you to today's conference session on Hodgkin's lymphoma. We appreciate all that are able to attend live today to learn more about the disease-specific biology and diagnosis of Hodgkin's lymphoma. This presentation will highlight novel research and treatment options that are accessible to lymphoma patients across Canada. And now before I introduce today's speaker, I'd like to provide you some guidance on the Zoom software for this session. This software does not allow you to share your video or microphone. If you have a question, please save it for the Hodgkin's lymphoma Q&A session following this presentation. And this is where you can ask your question to the presenter live. And now I would like to introduce and welcome our speaker, Dr. Shruthi Kodad. She completed her internal medicine residency and fellowship in hematology at Narayana Health in Bangalore, India, before joining the Leukemia MT program of British Columbia as a clinical fellow in 2016. After 2 years of her fellowship, she worked as a clinical associate in the Saskatoon Cancer Center and is currently working as a staff hematologist at the same cancer center. She has clinical and research interests in lymphoma, chronic lymphocytic leukemia, autologous and allogeneic stem cell transplants, and long-term complications of stem cell transplant. We thank you very much for joining us, and I'll turn over the presentation to you.
Well, thank you, Sarah, and thank you, Lymphoma Canada, for giving me this opportunity to be a part of the 6th Annual National Patient Conference. And thank you, everyone, for attending this, and thank you for that introduction, Sarah. So today, as we know, I'm going to talk a little bit about Hodgkin's lymphoma. So we will approach this topic into these subheadings. I want to tell a little bit about what is Hodgkin's lymphoma, how we came to know about it, what exactly goes wrong in this disease, what are the clinical features, how do patients actually present, and a little bit about diagnosis and management of this disease. So collectively, let's talk a little bit about lymphomas. So lymphomas basically are the cancers of lymphocytes which develop in the lymph nodes and spread through the lymph vessels. So the lymph nodes are nothing but they are bean-shaped organs in our body which basically make and store lymphocytes. And lymphocytes are white blood cells that have the ability to fight infections. For example, B lymphocytes, these develop in the bone marrow and they form antibodies and they actually protect and fight against infections. And the lymph vessels basically contain lymphatic fluid which carries these lymphocytes. And when there is uncontrollable growth of the cancer cells of these lymphocytes, they continue to grow uncontrollably and they can actually spread through these lymphatic vessels, which explains the contiguous spread of this disease as we know. Coming to Hodgkin's lymphoma, this was named after a physician, Dr. Thomas Hodgkin, who found and treated a series of patients in 1830s. They presented with very similar findings of lymph nodes, fevers, weight loss, and those kind of clinical features. They also found that there is some DNA damage of the lymphocytes, which can cause this uncontrolled growth of these cancerous cells. And that's why it gives rise to enlarged lymph nodes and masses in other areas where lymphoid tissue is found. It was Dr. Dorothy Reed who actually found the characteristic cell, which is responsible now basically to identify this particular kind of lymphoma. Initially, these cells called Reed-Sternberg cells, they were initially thought to be just a subclassification of tuberculosis. It was Dr. Dorothy Reed who actually found that these are not related to tuberculosis. These are separate cells which are found in Hodgkin's lymphoma. This was the original illustration by Dr. Reed as to how they actually came to know about the Reed-Sternberg cells. As you can see here, these are, multinucleated cells. And in today's day, we can see these when we do a tissue biopsy and see these under microscope, this is how they look, like multi-nucleated cells. And the background is also infiltrated with different kinds of Hodgkin cells, which are slightly larger than our regular lymphocytes. So all these characteristics are important to make this diagnosis. And they also express certain markers like CD15, CD30, which are basically the particular markers for Hodgkin's lymphoma. So what exactly happens with these B cells? We don't know what all transforming events are responsible for this. One such suggested event is an Epstein-Barr virus infection, which can cause some amount of disruption in the cells and give rise to the Reed-Sternberg cells. And the Reed-Sternberg cell have a unique ability to continue to proliferate and also not end that cell cycle, and they continue to just continue to grow. They also release cytokines, which are nothing but inflammatory markers and which can give rise to the fevers, the night sweats, the weight loss, which we see during the as a presenting feature of this lymphoma. Approximately about 1,000 people per year in Canada are diagnosed with this disease. It constitutes about 0.5% of all cancers and 15% of all the lymphomas. It has a bimodal age distribution. That means we see this disease in very young individuals, like in early 20s, and we also see the same kind of disease in individuals who are in their mid-70s. Men are more prone to get this disease, and sometimes we may need multiple biopsies to diagnose this lymphoma. The reason being, even though the lymph node enlarges, less than 1% of those cells are actually the malignant cells or the cancer cells. So it sometimes might take multiple biopsies to actually make this diagnosis. Good news is more than 75% of this kind of lymphoma is curable, either with chemotherapy alone or with a combination of radiation. Hodgkin's lymphoma is again subcategorized into mainly two categories. One is classical Hodgkin's lymphoma, and the second one is nodular lymphocyte predominant Hodgkin's lymphoma. And under classical Hodgkin's lymphoma, there are 4 different subgroups. They all behave almost the same way. There is no difference in their clinical behavior. Whereas the nodular lymphocyte predominant Hodgkin's lymphoma, we can see a particular marker called as CD20. And this subclass of this Hodgkin's lymphoma can behave more like an indolent or a slow growing kind of cancer, and it is more prone for late relapses or recurrences in the course of its natural history. Coming to, are there any risk factors to developing these Hodgkin's lymphomas? None of these risk factors are modifiable, but we have seen some associations with past Epstein-Barr virus infections in patients who have immunocompromised state. For example, somebody who has human immunodeficiency virus infection, they can be more prone to getting this kind of lymphoma. If there is a family history of Hodgkin's lymphoma, we see an increased risk in their first-degree relatives, and also there's 100-fold risk in the identical twins. Although there is nothing which is modifiable, so there is nothing which an individual can do or cannot do to prevent developing this disease. Coming to clinical features, so what do we usually experience or see? There might be just a painless, enlarged one lump or lymph node in the neck or in the groin or in the armpit. That's kind of the most common presentation which we see. Some patients present with a chest mass, a chest discomfort, unexplained shortness of breath, unexplained chest discomfort. And in case somebody has fevers without any explanation, there is no infection, but they're still having fevers. Night sweats, these are drenching night sweats, which an individual can wake up basically soaking wet and needing to change their bed sheets, and approximately 10% or more of weight loss in the last 6 months, again, which is unintentional weight loss. If these symptoms are absent, we say they have it's designated the letter A. And if they are present, then these are the B symptoms which we talk about. Some patients present with just intensive itchiness, just generalized itchiness with or without a skin rash. Sometimes people also experience a little bit of pain in the lymph node after consuming alcohol. Now coming to how is this disease staged and why is this important? So staging is important in Hodgkin's lymphoma because based on the staging and certain risk factors, we actually individualize treatment in different patients. So similar to other lymphomas, Hodgkin's lymphoma also is staged by an Ann Arbor classification. So stage 1 means there's only one group of lymph node is involved. Stage 2 is two or more group can be involved, but it has to be just above the diaphragm or just below the diaphragm. And stage 3 basically involves both lymph node group involvement in both up and below the diaphragm, and stage 4 can have an extranodal or like a bone marrow involvement and any other organ involvement that can be designated as stage 4. So stage 1 and stage 2 are collectively grouped as a limited stage disease, and stage 3 and stage 4 are collectively grouped as advanced stage disease. I'll talk a little bit briefly about risk stratification, because this is going to be important when we are trying to determine which is the best treatment for a patient. This is the German Hodgkin study group criteria for Hodgkin disease. As we see in the box on the right side, these are the risk factors which we see if there is a large mediastinal mass, which is more than one third of the horizontal chest diameter. If there is extranodal disease, elevated erythrocyte sedimentation rate, which is determined by a blood test. And if more than or equal to 3 lymph node groups are involved, if any of the risk factors are present, then that particular group will be designated as unfavorable. So early unfavorable or early favorable basically means there is stage 1 or stage 2 disease without any of these risk factors. Early unfavorable means there is stage 1 or stage 2 disease with one or more of these risk factors. And anything which is stage 2B, along with a large mediastinal mass or extranodal disease, we would consider it as advanced stage, and stage 3 and 4 are anyway considered as advanced stage. Coming to diagnosis or workup of this Hodgkin's lymphoma, the first 2 bullet points which I have noted here, the excision lymph node biopsy and a PET scan, these are like the most important tests in determining not only the diagnosis, but also with the staging of the disease. Because as I mentioned earlier, only less than 1% of the cells constitute for the malignant cells, it's important that a whole lymph node is removed and then sent for examination, and not necessarily just taking just the liquid part of that lymph node and sending it for just cytology. We may not get any result with that test. A PET scan, I will be talking about it in my next slide. So that is basically a kind of medical imaging which we do to see if all the groups of lymph nodes which are involved, and whether to some extent we also can tell whether the bone marrow is involved or not. Along with this, we also ask for a lot of blood tests, including some viral markers. We want to see what the cardiac function is. We want to see what the lung function is like. And these are done basically to determine how well an individual can tolerate the chemotherapy options available. Bone marrow aspiration and biopsy is done in some individuals, but it's not requirement. It's not a general requirement, because PET scan actually can tell us whether the bone marrow is involved or not in most conditions. In case if there is just a limited stage disease, but the PET scan is not very suggestive of either or, whether there is bone marrow involvement or not, then in those cases, doing a bone marrow aspiration and biopsy might be helpful, especially if there are discrepancies in the cell counts. If we are seeing some anemia, if we are seeing low platelet counts, then it might be useful. Now coming to what is a PET scan. So a PET scan is basically an imaging modality where we use a very low dose of radiation. And this is given, it has an IV contrast, which basically is like a radioactive sugar, like IV contrast. And this is how we read the images. So whenever there is active lymphoma, it lights up or it gives a brighter signal, so that we will be able to identify exactly which groups are more active and involved. And this is also an excellent modality to determine what is the response to the, after therapy, because after therapy, in case there is no light up, it's very, very sensitive to actually pick up any residual lymphoma activity. So the PET scan is a very good modality. So it's usually used definitely in Hodgkin's lymphomas, but also in other aggressive types of lymphomas like diffuse large B-cell or Burkitt lymphoma. We're always worried about radiation exposure whenever it comes to such a scan. Good news is that PET scan is also done total body PET scan. It definitely has much less radiation than a conventional CT scan. So a conventional CT scan will have expose us to radiation which is equivalent to about 250 chest X-rays, whereas PET scan will expose still us to about 120 chest X-rays worth of radiation. So a PET scan not only is a better modality, but it's also much safer than a CT scan. Coming to the treatment options, we spoke about the staging, we spoke about the risk factor stratification. They are definitely an important part in trying to determine what is the best treatment modality. But the most important part is knowing the patient, especially what is the expectation of the treatment, how is an individual's fitness to tolerate this treatment, not just the physical fitness, but also the emotional component to it. We have to establish a goals of treatment at the very beginning, whether it is curative intent, whether we are just trying to prolong the disease control, or just we are trying to achieve symptom control. In Hodgkin's lymphoma, this is one of the very few cancers where more than 80% of patients are curable, and it is at all stages. So regardless of the stage, the cure rates are very high in this Hodgkin's lymphoma. And as we can see here in this graph, with the standard treatments, these are the standard chemotherapy regimens, which I'll be talking about in a minute. With these standard regimens, we see more than 80% of the patients are actually cured and have a very good survival rate. We like a risk stratified approach because of this, because so many patients can actually have a potential of cure. We want to minimize the toxicities when we are offering treatment, because all chemotherapy definitely comes with some amount of toxicities. And that's where the risk stratified approach comes into the picture. So we have learned a little bit about how we stage and risk stratify. So in limited stage disease, that is stage 1 and stage 2, we use a standard combination of ABVD regimen. So this is just an acronym for the components of chemotherapy, which I've listed on the right side. So adriamycin, bleomycin, vinblastine, and dacarbazine. These are the components of the chemotherapy. And in red, I have listed out the toxicities, or the most common toxicities associated with this particular agent. So we do 2 cycles of ABVD chemotherapy. We get a PET scan done. And if the PET scan is negative, that means there is no uptake, there is nothing brightly lighting up, and whatever was lighting up beforehand has all disappeared, then depending upon what risk it is, if it is favorable risk, then we either can give 2 more cycles of the same chemotherapy, or try to achieve the kind of response with what we call as an involved site radiation therapy. So that is the acronym ISRT. So what is involved site radiation therapy? So that is a kind of radiation treatment which targets the lymph nodes where the disease had first started and just the surrounding structures. By limiting the exposure to radiation to just that one particular area, we are able to protect the other organs, the surrounding organs, especially the lungs or the thyroid gland, from unnecessary effects of radiation. So this modality is used in the favorable risk population. If somebody has unfavorable risks, the risk factors which we spoke about, the high ESR, more than 3 groups of lymph nodes are involved, or there is a huge bulk of disease, then we try and use 4 more cycles of the same kind of chemotherapy. Supposedly, the PET scan after 2 cycles of treatment is still showing some uptake, and we think that this is all residual lymphoma. Then there is an option to escalate the chemotherapy. And this escalation is usually done by using this protocol called BIACOP. It involves bleomycin, etoposide, adriamycin, cyclophosphamide, vincristine, procarbazine, and prednisone. The procarbazine and prednisone are given as an oral therapy. Others are given as an IV treatment. The problem with this regimen, because it's definitely more aggressive than the ABVD regimen, it's more toxic. So it can be a little bit more harsh on the body. It also has a risk of infertility. So especially when we're dealing with really young population, we have to make sure that we counsel them about the possibility of infertility and see if we can do any kind of fertility preserving measures prior to starting this treatment. So after giving 2 cycles of BIACOP, then we, this is also consolidated, that response is consolidated by giving some involved site radiation therapy. So this is the approach in the limited stage. So we can omit the bleomycin in the last 2 cycles because it has a higher risk of causing this pulmonary toxicity. And there are studies which have already demonstrated by omitting the bleomycin, we are not losing any benefit of that ABVD chemotherapy. We still get the same kind of response even after omitting the bleomycin in the last 2 cycles. So this is a little bit more complicated slide, I should say, but this is mainly used, or this is just a guideline which is proposed in the ESMO. And this is the approach, a general approach in advanced stage Hodgkin's lymphoma, that is stage 3 and stage 4. In some centers, we do use 6 cycles of escalated BIACOP at the very front line. But again, as I said, there is a high risk of infertility. There's a high risk of toxicity. There is a high risk of secondary malignancies in the future, especially some myeloid disorders or bone marrow affecting disorders in the future. So instead of that, we could also do 2 cycles of ABVD, which is kind of the standard practice in our center here, and then still use the PET-CT scan to guide that treatment. So if the PET scan is still showing some uptake and still showing residual disease, then we have an option of increasing the chemotherapy to 4 cycles of Biacom, only in individuals who can tolerate such an escalation, or we also have an option of continuing 4 more cycles of the same ABVD, and again repeating a PET scan. If the PET scan is still positive, then use radiation therapy to wherever there is some residual lymphoma activity which is going on. If the PET scan is negative, then we just use a standard approach. We complete 4 cycles of AVD. Here, as you notice, we can actually omit bleomycin in the subsequent 4 cycles and repeat a PET scan. If it is PET negative, then we continue with observation. There is another approach to the advanced stage Hodgkin's lymphoma. This includes involving a novel agent in the regimen. And in Canada, we are using this for stage 4 Hodgkin's lymphoma. The name of the medication is brentuximab vedotin. It is a targeted antibody drug conjugate, which is an anti-CD30. And this is used in combination with the other 3 medications, that is adriamycin, vinblastine, and the dacarbazine. So here, as you notice, we do not use bleomycin along with the brentuximab, just because there have been trials and there was increased toxicity when we used bleomycin and brentuximab together. This regimen is proposed, and it is actually a better combination to use in stage 4 because it has shown better overall survival and also a longer disease-free survival compared to the ABVD, the classical ABVD. However, it does come with some side effects. The side effect profile is slightly different than ABVD. It doesn't, there's still definitely low white cell count during this treatment. Some patients experience a lot of diarrhea. We have seen a lot more neurotoxicity, so a lot of tingling and numbness in the hands and feet. And to some extent, also a more advanced rate of peripheral neuropathy or neurotoxicity is seen. We also see lung toxicity with the same agent called brentuximab, just as very similar to bleomycin. So these are the things which we keep in mind. So now we have all these options in front of us. We have completed treatments. And how do we evaluate response? So if we are not using a PET-guided therapy, especially when we use the brentuximab AVD regimen, we usually do not use a PET-guided therapy, in which case in limited stage, we do a PET-CT scan definitely after 4 cycles and just before using radiation therapy in advanced stages. In a PET-guided or a PET-adapted approach, we, as shown in the flowcharts before, we do a PET-CT scan after 2 cycles of treatment. And then patients with advanced disease, we do a PET scan after the end of chemotherapy. And for final staging, regardless of whatever disease group they are in, physical examination, the lab analysis with a complete blood count, and also including the kidney function test, the liver function test, that is all mandatory. Based on this, based on if some patients are, when patients are in good response or they have actually achieved what we call a complete metabolic response, we still follow these patients at least for 5 years. The reason is the risk of relapse is really high in the first 2 years. And that's why this is a recommended guideline to follow these patients closely in the first 2 years, every 3 months. And then for the 3rd year, we follow them every 6 months and then once a year. During this follow-up, we definitely do physical examination. We ask for blood tests a complete blood count, ESR in case if it was high at baseline. We look for the kidney functions and liver functions. If there are patients who have received radiation to the neck, then we also look at their thyroid functions. We make sure that they are vaccinated completely, they get their flu shots every year. The imaging studies, we do not, patients who do not have any uptake at the end of treatment, they really do not need any PET CT scan surveillance going on. So that's actually a good news that reduces the risk of exposure to radiation. Mostly we will be able to catch the relapse either with symptoms, the B symptoms, if they were there before, they could come back. We could start seeing something in their blood work, especially the lactate dehydrogenase can start going up. Some of the symptoms like that intensive itchiness can actually come back. Also, if patients experience a new lump, then that will be investigated. Despite all the precautions and because of these intensive regimens, there could be some reproductive issues. There could be cardiovascular risks of cancer and its treatment. So counseling regarding following a really heart-healthy diet, following an active lifestyle, speaking out about the reproductive issues and seeking help when it is necessary. These are all very much important when it comes to the long-term follow-up. So after 6 years, we can still continue, or we do still continue doing the annual physical examinations, and sometimes we refer them to their family doctors for this. An assessment of cardiovascular risk factors needs to be done at each annual physical examination. Vaccination should be kept up to date. After 10 years, it is worthwhile doing a stress test or an echocardiography because there is always a risk of cardiotoxicity in all of these regimens. In patients who have had radiation therapy, especially to the neck, they might need ultrasound of the carotid artery after 10 years. Blood tests annually, the same kind of blood tests which we do initially, those have to be repeated, including thyroid function tests in people who have received radiation treatment, especially in women who have received radiation treatment to the chest area or near the armpit. They should definitely have mammograms once a year, at least starting around 10 years after the treatment or at age 40, whichever comes first. And if younger women are there, then adding an MRI and an ultrasound to that breast cancer screening will definitely be helpful. Coming to long-term follow-up, in long-term survivors, the annual examination can still continue. There is definitely a need to continue monitoring their thyroid function tests, the testosterone and estrogen levels, basically to see how their hormone health is like. Educate them about long-term toxicity, especially affecting the lungs and the heart. And the breast cancer screening is definitely mandatory in long-term follow-up, especially in women. Coming to the group which do not, so we know that more than 80% of patients do respond, but there is close to 10 to 30% of people who do not. So 5 to 10% of them do not respond to the first line of treatment, and they just continue to progress. And about 10 to 30% of patients may have a relapse even after achieving that complete remission after the first set of treatment. In such patients, we definitely have to discuss the goals of care again, and the way or the one modality to try and achieve good control of disease is by giving a different kind of chemotherapy and trying to basically consolidate that response with a high-dose treatment and autologous stem cell transplant. So whenever there is either a relapse or we see that there is no response to first line of treatment, the first thing we should do is definitely repeat a PET scan and get a biopsy done to confirm that this is still Hodgkin's lymphoma and there is a relapse which has happened. before proceeding with treatment, I always like to discuss about stem cell transplant and kind of determine if an individual is eligible to go for stem cell transplant, because that is going to guide us in the next treatment steps in this patient population. The reason why we want to use more chemotherapy before the stem cell transplant is for one, we have to decrease the disease burden. And how do we do this? We do this by either using a second-line chemotherapy protocols. We could do this with combination with chemotherapy and radiation, or by using a targeted therapy option. So second-line chemotherapy options, these are some of the regimens which are followed across the world and across Canada. And most commonly, we have experience in using GDP regimen, which is gemcitabine, dexamethasone, and cisplatin. The toxicity profile is definitely a little bit different than what we have used earlier compared to the earlier regimens. In this protocol, we do notice there is some amount of neurotoxicity. The peripheral nerves can get affected. Hearing can get affected. There is still a higher risk of infections in individuals who are receiving these different kind of chemotherapy regimens. Generally, this is given for 2 cycles, and then after 2 cycles, another PET scan is repeated to basically demonstrate whether this disease is chemosensitive or not chemosensitive. So chemosensitivity is basically whenever a patient receives chemotherapy and we repeat a PET scan, and if the disease is coming under control, or either like reducing more than 50% or just completely disappearing, that is what we would define as chemosensitive. And why is it important to determine whether this disease is chemosensitive or not? Is because whenever there is chemo resistance, that means even with different lines of treatment, the disease is not able to come under control. And if somebody still underwent a stem cell transplantation, the survival was not good. So as you can see here, in patients who responded really well to the second-line chemotherapy or any chemotherapy, and then subsequently underwent an autologous stem cell transplant, their overall survival was much, much longer and much better. So just briefly, what does autologous stem cell transplant involve? It involves basically 4 steps. One is apheresis, next is conditioning chemotherapy, next is reinfusing stem cells, and then engraftment of stem cells. And in some centers, this is all done as an inpatient. In some centers, it is also provided as an outpatient service. So what is apheresis? Apheresis is nothing but trying to, we give some growth factor injections, and then we mobilize the stem cells. Once after determining that a patient is actually fit to undergo this whole stem cell transplant. And how do we determine the fitness? We basically see how is their performance status, how is their organ functions. We check the lung function tests, we check the another echocardiogram. We also check their organ functions like liver and kidney functions. And if everything is meeting the parameters, then they are determined to be transplant eligible, and they can undergo apheresis, which is nothing but collecting their own stem cells. And this is done by giving those growth factor injections, which I just spoke about. We mobilize the stem cells. It's exactly given, the process is very similar to blood or plasma donation or platelet donation. So the blood kind of circulates through a machine, the stem cells are collected, and the remaining of the blood is given back to the patient. These stem cells then are preserved in a preservative called DMSO, and they are frozen. Now, a patient gets admitted after this stem cell collection. Patient is admitted into the hospital, and in some institutes it's done as an outpatient protocol completely, and they receive high-dose chemotherapy called conditioning chemotherapy. Now, what is the necessity to give again a conditional chemotherapy? So this is one to kill as much as lymphoma as possible. So if there is like micro residual lymphoma here and there, then this high-dose chemotherapy is going to eliminate that, and also to kill all the stem cells. So we already have stored the stem cells separately. So the conditioning chemotherapy achieves these two things. Then later, the next step is to reinfuse these frozen stem cells. So these stem cells are thawed in a water bath and they're again reinfused, and this is done through intravenous route. It just feels like a blood transfusion. Some people do get nausea. Some people do get a weird taste or a garlicky taste in their mouth because of that preservative called DMSO. And once the stem cells are infused, it takes about 2 to 3 weeks for those stem cells to repopulate the bone marrow and start growing again. And this is when the engraftment of stem cells happen. So after this process of autologous stem cell transplant, patients generally need at least 3 months or 6 months to recover. They will be very tired. Their childhood immunity is also completely wiped out. So after 3 to 4 months, the COVID vaccinations now are they're all revaccinated with the COVID vaccinations, and then gradually even the live vaccines will be given to them later around a year mark. So this is an extremely immunocompromising kind of treatment. So patients are definitely advised to stay isolated and not go into crowds, and also to report back to their institutes in case if there is any signs or symptoms of infection after undergoing such a treatment. So coming to what other modalities are available to try and control this difficult group of cancers, which are just are resistant to chemotherapy. So now we have options of what we call as targeted agents, and these targeted agents basically target particular markers on the cells. And one such marker is CD30, and the brentuximab vedotin targets the CD30 and tries to achieve a good response and kill those cancer cells which have actually shown no response to chemotherapy. This is given as an intravenous route. It goes every 3 weeks and generally given for 16 cycles, especially in patients with who have a high risk feature. For example, they were chemo sensitive, but then they were not responding to the first line treatment. They were just refractory and progressed soon after the first line treatment. They have achieved response after getting the second line treatment and the stem cell transplant. In such individuals, we can use this brentuximab vedotin as a maintenance therapy post stem cell transplant to continue that good response which we achieve post transplant. Rituximab is also one such targeted agent which we use, and this is used once a week at 375 milligrams per meter square for 4 weeks, and this is used particularly in that subclassification, the next other subclassification which we spoke about, the nodular lymphocyte predominant Hodgkin's lymphoma, and this targets CD20. Coming to the other group of novel agents, there are something called as immune checkpoint inhibitors. So what are immune checkpoint inhibitors? So and why is it important? So as our immune system usually stops itself from attacking the normal cells by using specific proteins called immune checkpoints or checkpoints. These are made by the immune system cells, and lymphoma cells can be sneaky and basically try and trick the system and use these checkpoints and get to avoid being killed by the natural defense mechanism of our body. So this is where the immune checkpoint inhibitors, they work by blocking these checkpoint proteins, and basically the immune system cells, especially like the T cells, they have an opportunity to attack and kill the cancer cells. Two such commonly used agents are pembrolizumab and nivolumab. These two agents work by blocking the PD-1 checkpoint protein, and they can attack and kill the cancer cells. These both are given IV. Pembrolizumab is given every 3 weeks, nivolumab every 2 weeks, and this is given until disease progression. At this point, we do deem the cancers probably not curable at this point, and this is given until disease progression. And some of the side effects of these immune checkpoint inhibitors, they do come with unique side effect profile because these are targeted agents. They can cause infusion reactions when the IV infusion is going on. Some patients can have fever, skin rashes, chills when the IV infusion is going on. Later, this can also cause autoimmune-like reactions, which can affect the lungs, which can affect the kidneys, sometimes the liver and the intestine, can cause like thyroiditis and then hormone problems. So this group of new agents definitely has a unique side effect profile, which we have to identify, and then those side effects have to be managed accordingly. Coming to what newer advances we see in Hodgkin's lymphoma. We hear a lot about CAR T-cell therapy in the lymphoma world now. So what is CAR T-cell therapy? So we collect, CAR is nothing but a chimeric antigen receptor. We collect blood of patients, then isolate the T cells, and these T cells are actually reprogrammed and grown. And once they are grown, they're injected back into the system. And these are the chimeric antigen receptor T cells. They have a unique mechanism, and they go and keep growing in the body and also attack those cancer cells. This is now being approved and used in other kinds of lymphomas like diffuse large B-cell lymphoma, high-grade follicular lymphoma, primary mediastinal lymphomas. In the Hodgkin's lymphoma world, this research is still in the early stages. There are parallel phase 1, phase 2 studies which are going on. They are showing promising results. So we'll have to wait and watch as to what is going to be the outcome of this CAR T-cell therapy and where we are going to use it. There are other targeted agents which are coming. An anti-CD25 antibody drug target is coming. It is called as camidanlumab. It is also in very early stages of research. There is a phase 1 studies which has shown promising results. So there is a lot to look forward to in terms of newer advances in the Hodgkin's lymphoma treatment. With that, I end my today's presentation. Hope you enjoyed it, and I'll be happy to take any questions.
Thank you, Dr. Kodad, for your excellent presentation. We really appreciate your review of Hodgkin's lymphoma, detailing the treatment options available for patients in both the frontline and refractory settings, and the current treatment options that are available for Canadians. I now like to direct our audience to attend the Q&A session that's following this presentation, where you can ask your questions live to the presenter. Thank you so much.
Thank you.